Hello, and welcome to Let's Get It Straight. In today's segment, we're going to review the new updated HIV post-exposure guidelines. I'm Katherine West, infection control consultant, and I'll be presenting this current information to you today. If you're surprised that there are new guidelines published in July of 2025, you're not alone, because they were not published by the CDC. As you are well aware, there are many changes going on at the CDC, and so other authoritative groups such as the Society of Healthcare Epidemiologists of America, OSHA, are helping to get important information out to those of us who will benefit from it. First, sort of a disclaimer. We're going to accept data from CDC that was published through July 25th of 2025. We will consider that information to be evidence-based. Now, after that date, July of 2025, it will be important to verify information before you accept it. Now, the National Institutes of Health created a guide for evaluating scientific trustworthiness. I recommend that for easy reading, 2 pages, to all of you. So let's make sure we're on the same page and define evidence-based practice. It's a process that uses the best available evidence, clinical expertise, patient values to guide healthcare decisions. The goal is to improve patient outcomes and quality of care by incorporating the best research into clinical practice. Now, HCPAC. That stands for Healthcare Infection Control Practice Advisory Committee. HCPAC was an advisory group to the CDC. It would review evidence and make recommendations regarding improving, changing, updating current information. And they were on a path in 2024 to upgrade the 2007 Infection Control and Isolation Guidelines. Now, their last meeting was November of 2025. So they use a system to review and make recommendations to CDC, and it's called GRADE. And they look at recommendations, assessment, development of new ideas, and evaluation of existing studies. Now, their last meeting, as I said, was November of 2024. And after that, this committee was disbanded, and there is no replacement. And that's why we're going to accept data currently through July of 2025 with our new HIV post-exposure guidelines. So these new guidelines are written for and hopefully will benefit the following groups: leaders and staff of occupational health services, emergent and urgent care providers, primary care providers, and human resource personnel. So the CDC conducted extensive literature review on the recommendations of HCPAC, and the new guidelines were voted on, and they have 3 categories. First, straight up front recommendations by CDC. The second group are called conditional recommendations, and the third recommendations that were formed by literature review and termed good practice statements. In looking at past published HIV post-exposure prophylactic guidelines, we had those from September 30th of 2005. The next update was 2013, and now this one in 2025 reiterates some of the documents and information from the 2013 publication and adds new information as well. So what's changed? What's new? Well, number one, we were told in the 2013 guidelines that the new prophylactic antiretroviral drug regimes would be less toxic, and that is reflected in this document. Number two, there's a shortened duration of post-exposure follow-up HIV testing, and we will review each of these. There was an elimination of doing baseline and periodic laboratory tests for persons who are on PEP to determine whether they were acquiring any drug toxicity. And lastly, consideration for PEP for healthcare personnel with exposures to source patients with undetectable viral loads. As we now know, people who are taking their HIV treatment and they will have blood work looking for viral load, how much HIV virus is circulating in their blood, and we find out it is undetectable. We'll talk more about this in a few minutes. Now, one point that's made very strong throughout the new guidelines is that post-exposure follow-up for HIV should be conducted by an expert. So, they define an expert as a healthcare professional with expertise in HIV treatment, antiretroviral medication use, and determination of HIV exposure risk. And you will find this statement on page 4 of the new guidelines. Now, just to make sure, because we are still finding that people are following OSHA statement that anyone who has an exposure has to immediately be tested for baseline. And that is not currently the case and has not been since 1999, when OSHA clarified that when they use the word immediate, they didn't mean immediate, that an exact time was not given because the time limit varies with each disease. So at that point, 1999, HIV follow-up was worded as to be within hours but not days. So if fire, EMS, law enforcement personnel have an exposure, they do not need to sign in to an emergency department and have baselines drawn. Everything starts with testing the source patient. Why is it different for fire, EMS, and law enforcement? Because they fall under the Ryan-White law. And things are different in this law as how they follow up exposures. The person in charge of managing exposures for them is their designated infection control officer. So what about testing the source patient? That's the hospital, the medical facility's only responsibility is to test the source patient. And that is clearly stated not only in OSHA, Ryan-White, but in each state's HIV testing law. So you need to be familiar with what is in your state HIV testing law. Your designated officer should be very well versed regarding that. But it's important for you to know as well. And these laws differ in pretty much every state. However, more than half of the states have an exception in their HIV testing law to requiring patient consent. And it states that if there has been a healthcare worker exposure, then there is an exception to needing patient consent to do the testing. A very important point. So let's review HIV risk data. What is the risk for acquiring occupationally HIV? And these studies, as you can see, started back in May of 1998 and have carried through to July of 2025. So currently, the risk for acquiring HIV infection from a needle stick injury is listed at 0.23%. Now let me describe the type of injury that led to healthcare workers acquiring HIV through occupational exposure. It involved a deep stick with blood on the device causing the stick. The device had been in the patient's vein or artery. The patient had a high amount of HIV virus circulating in their blood and involved a large gauge hollow bore needle. The risk for acquiring HIV from mucous membrane exposure, such as blood splatter to the eye, is 0.09%. And there was just one case of transmission of HIV through non-intact skin, and that was back in 1985. So risk for contracting HIV in the healthcare work environment is low. There's another important statement in the guidelines, and this is supported by OSHA, Society for Healthcare Epidemiologists of America, as well as CDC, that healthcare worker exposures to HIV that occur outside occupational health clinic hours and at sites at which occupational health services are unavailable, and initial exposure management is often overseen by emergency physicians or other providers who are not experts in the treatment of HIV infection or the use of antiretroviral medications. They are to call the PEP hotline. They are to get a second opinion from the PEP hotline with regard to the appropriate use or the non-recommendation of offering PEP. It's a real important statement. Now, the CDC held an EMS physician focus group, and the discussion revealed 3 challenges. So the physicians themselves have stated that these are 3 real concerns that they have. That evaluation of source unknown or a patient who refuses testing, how that should be handled in your state. That they have inexperience in managing occupational HIV exposures, and that proper counseling of the exposed healthcare person in a busy emergency department is often quite problematic. So this goes to the importance of your departments assessing who to designate to do your department post-exposure follow-up and counseling. Now, what about post-exposure testing? There is no window phase. Not since 2005 is there a time frame where a patient with even undergoing rapid testing would test negative and later become positive. No, the rapid tests that are used today, there are 8 in the marketplace, 5 of which are CLIA waiver, are very, very accurate. In fact, to get a CLIA waiver, a test must be easy to perform, their finger stick, and they have to be accurate. Now, if the source patient is tested and they test positive for HIV and they have viral load, they have circulating virus in their blood, then we will do baseline testing on the employee and test them again 12 weeks later. And that's the end of it. No further testing is done unless, as you see bullet number 3, we would test 4 months later only if the person missed doses of PEP that had been prescribed, or the source patient was co-infected with hepatitis C. Then at 4 months, we would test them for Hep C. So we can bring concern about having acquired HIV occupationally to closure now in 12 weeks. PEP drugs need to be available at all times. As we know, most of our exposures occur in the middle of the night, on weekends and holidays. So we have to have a system to have access to the medications at all times. Now, if you have, for example, an infectious disease practice following your exposures, then they most likely have quick access to the medications. We have up to 72 hours to start PEP drugs. That's great, because if something occurs in the middle of the night on the weekend, we have time to get an exposed employee into expert post-exposure care and counseling. And remember, everything is to be at no out-of-pocket cost to the employee. Now, what about follow-up? You know, a lot of our chiefs are not aware of the fact that whoever is doing your post-exposure follow-up and counseling is only acting as an agent on behalf of your department. The department holds the liability if things are not handled correctly. This is stated again in the 2025 guidelines. And remember, OSHA is enforcing all of the CDC post-exposure guidelines. So the document states, employer must provide confidential medical evaluation and follow-up following an exposure incident. So what about an exposure to a patient known to have HIV, but they have undetectable virus? They have no virus that shows up in their blood when they're tested. Now remember, a key to risk for contracting a disease, an important factor is dose, number load of organism present to cause infection. So here, it's really important that we refer a provider, exposed employee, to a provider with expertise in HIV treatment and counseling with regard to how that employee feels about accepting that the patient is negative, for circulating virus, and risk has not been documented for disease transmission? Or do they want to elect to take PEP? And what about source unknown? Again, consult provider with expertise in HIV treatment. And again, we're using that term, shared clinical decision making, involving whether they want to start PEP or if they've started PEP, perhaps having that discontinued. And you will find that addressed on page 4 of the guidelines. So we have newer PEP drugs that came out after 2013. And if an individual meets the criteria for PEP, we want to have consultation available by an expert 24/7. It's important for them to know that the newer drugs are considered less toxic. And therefore, this document removes the need for baseline testing and periodic testing every 2 weeks for anyone who elects to go on PEP treatment. You may not be aware that the CDC recommends universal screening for HIV, that anyone between the ages of 13 and 64 should get tested for HIV at least once as part of routine health care. For those at higher risk, testing is recommended to be done annually. We do currently actually have a plan to eliminate HIV as an epidemic in the U.S. by 2030. Let's hope that current plans and programs will continue so that we can meet this very worthwhile goal. Just remember, to have scientific validity, we need at least 3 studies conducted the same way that yield the same result to have scientific validity. You can probably find at least one statement to support just about anything, but that doesn't cut it. 3 studies conducted the same way that yield the same result. If you have any additional questions or need additional information, please feel free to contact me and share this information with your designated infection control officer and whoever is charged with your post-exposure medical follow-up and counseling. We want to make sure we keep everybody up to date. And I hope you will join me again in the future for another segment of Let's Get It